So welcome guys to the final presentations. Thanks so much for all your hard work. This is track A's final presentation, so hopefully everyone's in the right place. If you're waiting for team members, please encourage them to get here as soon as possible. So just a reminder for everyone as well as the judges, track A was getting patients' samples to labs for analysis. So across Africa, most COVID-19 testing capabilities exist at central labs in major cities. Patient samples for testing are collected in local communities and must then be transported to these centralized labs. Given transportation infrastructure challenges and extremely remote sample collection facilities, how can we make this process more efficient? So the teams have been working over the past 48 hours on coming up with ideas for this. For those that want to understand the judging criteria a bit better, the judges will be looking across these 4 things: impact, innovation, implementation, and presentation. So for impact, does the solution solve an ongoing or anticipated problem? Is there potential for widespread public health impact? And does it address the important challenge from the prompt that we just went over? Innovation, does the team provide a convincing rationale for why their solution may work? And does it address significant tech issues? Implementation, can it be executed? Presentation, how effective was the presentation? As well as, does the team have a diversity of backgrounds that lends credibility to the solutions proposed? So that's what the judges will be looking at and grading on throughout the day. Now, to introduce our track judges, we have 5 amazing judges today, and I'll let them kick it off in the order on the screen. So starting with Emmanuel, if you can just do a short introduction, that would be great.
Okay. Hi everyone, my name is Emmanuel Benyongo. I lead the coordination for the state's Public Health Emergency Operations Center currently in Nigeria for the COVID-19 response. Thank you.
Good morning, everyone. My name is Jennifer Dent. I work for BioVentures for Global Health and have a history working in the private sector for biotechnology and pharmaceutical companies.
Hi, my name is Travis Hunter. I direct the MIT Regional Entrepreneurship Acceleration Program. We work with over 50 different countries and how they support innovation and entrepreneurship in their particular region.
Hi, I'm Stephen Koltai, and I'm a Senior Advisor for Entrepreneurship at MIT's D Lab and also Research Affiliate at MIT MISTI.
Greetings from Vermont. My name is Rahul. I'm the CEO of the Suki Project, which does culturally sensitive mental health work and corporate mindfulness. Previously, I worked for the UN at the World Food Program in Ecuador, as well as on a USAID project in Uganda doing HIV work.
Awesome. Great. So we have a great list of diverse judges who will really be able to analyze all of your presentations. So thank you guys all for being here. We really appreciate your support. Okay, so in terms of judging, in terms of just general judging logistics for how today is going to work for the next 2 hours, logistics of final presentations. First off, you probably see it in your top left corner, but this presentation is being recorded. So you should know that if you want to share it for later or anything like that, all of these will be available. Next up, as we've talked about before, 1 member of your team will present. However, you can have other team members help with Q&A. You will have 3 minutes to present and 2 minutes for Q&A. So you should probably expect, we were just talking to the judges about this, like 1 to 2 questions for the Q&A. The order you present is random. We'll tell you that you're up next, so you will have 5 minutes to prepare. If you will be presenting for your team, please raise your hand and the host, me and Perna, will tell you when to unmute. So I think we just went over how to raise your hand, but there's a feature if you hit participants of how to raise your hand. We'll go over it in 1 more second, but that will be the way we will get to you. When it is your turn to present, you will unmute and turn your video on if you would like and have the capability, and I will flip the slides for you. You can just say next or something like that, and I will be ready to do it. I will give you, I or Perna will give you a 1-minute warning by holding up a sign in my camera. So please try to keep my image in the view. I'll just have a white piece of paper and can wave it. The judges will pick 3 winners per check. So Just to go over how to do this, you'll hit participants, raise hand. You'll wait for the host to unmute. You'll present for 3 minutes with one team member. The Q&A will last 2 minutes with 1 to 2 team members. And then we'll get ready for the next one. All right, any questions on logistics before we move forward? Great. All right. Oh, we have someone, Vignesh, you raised your hand.
Oh yeah, quick question. There's just like some additional documents we have as part of our presentation, especially a storyboard. I'm just wondering if we can add it. We did it before the submission deadline. So just wondering if we can drop the PDF in chat to.
At this point, no. I have a consolidated deck of everyone's slides that they submitted.
Got it. Thank you.
I had one question, Sarah. Do you want me to just like sound a little, instead of you holding up a sign, sound a little sound when there's a 1 minute warning?
Why don't you hold up the sign for 1 minute and a sound when it's over?
Okay.
Does that make sense for everyone? So have Purna in view. She'll hold up a sign that will say like 1 minute or something. And at time you'll hear a ding. So, and we will be strict on the time to the point that if you are going over, we will mute you. So please listen out for that.
Give me 1 second to write a sign out.
Great.
Sarah,
Is there another question? Yep.
I just wanted to ask, I assume that for the benefit of the judges, you'll give us the number of the team that's presenting before, since they're in random order. It won't be in order in our chronological, in our numerical dropdown.
It will be, yeah. We'll have all the team numbers as well. Okay. All right. Purna, tell me when you're ready to start the timer. This is how it will look, guys. So up first, congrats on getting it over with first. Will be A008. So Stephen, this will be the way you'll see it. XPHC, and coming up in roughly 5 minutes will be A034, Team Last Mile. So this is how it will run for the next 2 hours. You'll essentially know 5 minute warning. So we'll give PHC just a minute, just because they're up first. But if the XPHC team member who is presenting can raise their hand, that would be great.
Sorry, but I cannot find the raise hand. I'm the one of XPHC who will present.
Okay, no problem. Purna, just tell me when you're ready.
I'm just trying to shut down my notifications on Slack so it doesn't bother everybody constantly. Otherwise, my sign is ready. Do you know where the notifications can get turned off from? Might just quit Slack. Okay, you guys, we're running rogue. None of us. We're all here. I'm not on Slack anymore. You're either here or you're not gonna hear from us. Okay, this is what the sign looks like. Can everybody see it? Pin my video so you can see me.
Yeah.
Okay, great.
Great. Okay.
Ready? Shall we start?
So I has to share my screen, right?
No, I will be sharing the screen. So just say next when you want me to go to the next slide.
Oh, okay.
Are you ready, Jing Jing?
Yeah. Yes, I will share my screen.
No, Jing Jing, please don't share your screen. I am already sharing my screen. Can you see it?
Ah, okay. Yes. Sorry. I just talk, right?
Yes, you're just going to talk and you'll say next when you want me to switch to the next slide.
Okay. I'm ready to start.
Great.
Thank you.
Start.
Okay. Hello, everyone. We are the team XPHC. I'm a Chinese based in Italy, and I'm now with MIT doing a challenge to Africa. So we can see that all the world is facing the COVID-19 challenge. So And this is, since now the Africa confirmed case seems low, but we have an extremely low test number in Africa. The main reason is because competent hospital labs are very few and they are too far from the communities. So our challenge is to strengthen the healthcare system to face this problem. We found out that there is already a network of primary health care that in last decades has successfully covered large zone and have improved rural people health. However, the PHC has some limits. It's mainly due to the lack of infrastructure. To cover the lack of connection for the data between PHC and the labs, we will base our solution through SMS, because in Africa, the telecommunication signal is stable, while Wi-Fi is not. We will create an interface viable through SMS, connecting people, PHC and lab and the database of health management system, and while for the cooling problem, we will leverage on the existing public transport system, which will allow a frequent delivery and shorten the storage duration. So the condition will be also cut down, and a portable freezer will be enough. In the end, assembling all the blocks together, we will allow large community to get test and get results without moving far from their home. So we could expect a high rate growth for the testing numbers and getting more control of the pandemic, while in the other hand, the cost impact will be low. And as revenue model, we will be a non-profit. Thank you.
Thank you. Judges?
Yeah, I have a question. So let's say I'm a Matatu driver, or one of the local drivers. How does the platform look for me on my phone? What is my day-to-day interaction with the SMS systems, and how do I interact with the entire last mile delivery?
This is we thought this solution because David, our member who is Nigerian, get already experience when he studied in university in the city, and his family sent him each week a pack of food and money through the bus without present their parents be on the bus. So when the bus arrives, he just pick up. And this would be the similar situation that the PHC will put the box on the bus and communicate the lab about the target or we are still think if implement the transport system, but it could be also a simply message through the mobile phone of PHC to communicate with the lab, and the lab then gets the schedule and could be ready to pick up.
Okay. Perna, is that time on Q&A already?
Yeah, that is the time for Q&A that we have today.
Great. Thank you so much.
Thank you.
All right. Up next is 034 Team Last Mile, and coming up will be in 5 minutes will be 005 Co-Ventures. And it looks like 2 people raised their hand, if you can unmute them.
Yes. So is that Natasha that's going from Team Last Mile?
Yes, can you hear me right?
Perfect.
Yes. Great.
All right.
Are you ready?
Right. I think Team Last Mile is I'll be presenting for Team Last Mile.
Oh, yeah. Team Last Mile is first. Co-Ventures is in 5 minutes.
Oh, I'm sorry.
No worries.
No problem.
Meet yourself.
Awesome.
Thank you. Ready?
Abdallah, you ready?
Yep.
Great.
Okay. Hello.
Sorry, just to reiterate, and we'll restart the time. Please say next when you're ready to go to the next slide. It will make, or else I'm guessing.
Okay.
Thanks.
All right. Okay. We are Team Bridge the Gap, formerly known as Team Last Mile, and the problem we're hoping to address is how to connect patient samples to testing labs in a manner that is safe, fast, organized, and widely available. Current solutions to this problem involve patients visiting test centers for testing. However, these solutions are unsafe because they require the patients to leave their homes and unnecessarily engage in contact with others. And they're ineffective because they present a disadvantage to patients in remote locations without access to nearby testing facilities. Next. The solution that we're proposing to this problem has 2 major components. The first component is effective sample collection and transportation to testing labs by leveraging existing motorbike taxi transportation systems. The second component is an online platform for streamlining the management and communication elements of the testing process. Next. So why would this system work? By leveraging existing motorbike taxi transportation systems, there are a few distinct advantages. Our target areas are locations in which these systems are already present, which is the case in many communities around the continent. In addition, motorbike drivers are local. They know the area and can deliver samples quickly. And many drivers are also part of existing ride-sharing apps, which facilitate recruitment, training, and process standardization. In addition, this system also provides incentives for all stakeholders involved. The government and health organizations can reach many people even in remote areas. Taxi drivers can maintain their livelihoods, and patients can get tested safely. Next. Our platform relies on a smartphone or a USSD app that guides users through the sample collection and testing process. The collection process begins with registration on the app. The app provides 2 different user interfaces, one for the driver and one for the patient. The patient then submits a request that is linked to their geolocation. The patient is matched to a nearby driver. The driver is trained to safely collect the sample and equipped with the necessary kit and PPE, and the driver delivers the sample to the lab. The results are then linked to the patient ID and the geolocation and are communicated to the patient via the app and are sent to the government for further steps. Sorry, this slide was supposed to have an animation, but that's fine. Next, please. In order for this system to work, it requires some partnerships and collaborations, especially with the government, as well as with centralized health organizations. Next. So to summarize, Project Bridge the Gap addresses the issue of transportation of samples from patients to the lab in a manner that is safe, fast, organized, and widely available. This is our team. And thank you very much. Are there any questions?
I have a question. It's Stephen. Great job, Abdallah. Am I right to think that your solution does not address the availability of test kits themselves?
That's right. Our solution mainly focuses on connecting the patients, the samples, to the testing facilities. The kits themselves the availability of the kits themselves are not addressed by this solution. So this solution works with the assumption that the kits will be provided, and we're bridging the gap from the patient to the testing labs.
Thank you.
A question here too. Thanks. Nice presentation. Just to clarify that this solution assumes that the pickup rider, or the person coming to pick up the samples, is trained to collect samples.
That's right. Before the drivers can begin working with this program, they undergo a phase of training. And this training, as mentioned in the partnership slide, is conducted by health organizations. For example, in Nigeria, it would be the NCDC or any other organization that would collaborate with us. So they would train the drivers on how to collect the samples safely and how to use PPE. And so the drivers would assist the patients in sample collection, as well as transport the samples to the labs.
About 30 more seconds if anyone else wants to ask a question.
Yeah, I'd love to learn a little bit more about your team and your background.
Yeah, our team is quite diverse. I am a mechanical engineering student at MIT currently. Genevieve is a graduate from MIT Sloan, and she currently works in Nigeria. She is an entrepreneur and has a tech consulting and business consulting company. Manish is an electrical engineering student at IIT Delhi. Nathaniel is a medical student who studies in China, but he's originally from Nigeria. And Peter is currently a software developer in Kenya. And also my background as well. I'm originally from Sudan and I was born and raised there. So we have close ties to the continent as well as technical backgrounds.
Thank you.
Great. Thank you so much.
No problem.
All right. Just a quick pulse check. Technology is going okay for most people? Any major issues? Okay, sorry, just had to check. So up now will be Team A5, co-vendors, and coming up in roughly 5 minutes will be A3, Smart Mobile Labs. So Smart Mobile Labs, you're on deck, but if A5 can raise their hand now.
Oh, my hand is raised. Sorry, it's been raised.
Perfect.
Oh.
Then you are good to go. Start.
You can hear me, right?
Yep.
You can hear me? Hello? Hello?
Yes, we can hear you.
Okay, excellent. So welcome. We are the Avengers. Next. There is an absence of deliveries of the delays of COVID-19 test kits. This is what we find as our problem, that there is a lack of deliveries and delays of these test samples in rural communities. Next. So I'm going to highlight 3 key challenges to solve this problem. The first challenge, there's a lack of financial incentives for drivers. The second challenge is that there are poor road infrastructures in rural communities. And the third challenge is that there's the ability to check the integrity of the samples, meaning to make sure that they're in good condition, is lacking. Next, our solution. Yep. An adaptable system engaging drivers who are registered with local apps would be the way in which we would ensure that we are connecting the key actors involved. Next. How does it work? Our key actors are the rural healthcare workers in rural communities, the drivers, and the lab technicians. Next. So picture this. You have your driver, and your driver will be able to use offline navigations. Next. He can use these offline navigations by using a blockchain. This will help him to track where the locations are. Next. We have our lab technician, which will be able to use contactless exchange from the samples. The lab technician will also be able to have temperature control over the samples by using labels. Next. And we are also going to mobilize the community using the volunteers. So next, why in the world did we use Kenya? Well, 73% of Kenya's population is as a rural community. And so one of the few African countries that's already doing mass testing is Kenya. That is not supposed to happen, my apologies. One of the few countries that's doing mass testing is Kenya. There's a pre-existing system that's already installed using road mapping, and they already have adopted a regulatory framework that works. Next slide, please. We want to show you our team who came up with this brilliant idea. We have Josephine, Rudovic, Kanisa, myself, Yamoa, Vanessa, and Ghislaine. We are the Avengers. We are the Co-Vengers. Next. Please let us know if you have any questions.
Okay. 2 minutes. Judges.
I wanted to, that was very exciting. I wanted to just have you explain a little more the blockchain relevant, how you're
Yes, sure. I'm going to pass this over to Josephine, who's skilled in this area. Josephine, go for it.
Yes, hello. So the blockchain, we thought of using it. You said that it ensured correct navigation. I think there was a little confusion here. The blockchain would be used in order to secure the transaction between the health community worker and the driver, and then between the driver and the lab worker. So it would be to make sure that the data, like when was the transfer done, and where are the samples from, is correctly chained into the blockchain using smart contracts. And so this is an idea. We could also use a database, but discussing with the mentor, it seemed that this was a good use case for blockchain, because IBM has done it with a secure food program, for example, and the frameworks exist already.
Do you have other questions for us?
So who will your key partners be to be able to implement this program?
Thank you for that question. I'm going to turn this over to Ghislaine. Ghislaine, please, can you help her out there? Ghislaine.
Okay, Ghislaine seems to be offline. I can maybe pick a question.
No, okay.
Oh, cool, go.
Sorry. Can you please go? We have a slide we prepared especially on partnerships. So it's gonna be a three-way partnership with the government, the private sector, and your NGOs. So it's a cross-sectoral project. So we're thinking of partnering locally with Uber, Mondo, Little Mondo, and Pewin Caps, because these are already existing cabs that have a great system and they've been successfully working in Kenya. Also, we're going to be working very closely with the Ministry of Health, given that the right regulatory framework has been put in place. And lastly, we're going to be partnering with local NGOs so that they can train these drivers, and these NGOs would be Riders for Health. Riders for Health, next slide, please. Wheels for Health, and great. Riders for Health, Wheels for Health, and in Supply, which is a local medical logistics firm.
Great, thank you so much. Great.
Thank you so much.
Great job, guys.
Thank you.
All right,
Mute yourself so that the next team can come on.
great. Next up is A3, and coming up will be A32 in about 5 minutes. So if A3 can raise their hand. Got him.
See a raised hand for Smart Mobile Labs.
Smart Mobile Labs, are you there?
Oh, Moses.
Great. Moses, are you there?
Moses, can you hear us?
Yes, I'm here.
Great. You ready?
Hello. I can hear you.
All right. You ready?
Are you or Camille presenting?
Yeah.
It's Camille.
Username.
It's supposed to be Camille, but I don't know.
No, she's here. She's here. She just joined. Perfect. Camille, can you? Oh, Camille, we can't hear you though.
I'll look into unmuting Camille.
She's unmuted.
Okay.
Oh no, I'm here. Sorry.
Okay.
Can you hear me?
Yes, we can hear you
Okay,
perfectly.
great.
Are you ready?
Okay. Yes. Yes. I just turned off my video so that you can hear me better.
Perfect.
Yeah. Just tell me.
Yeah, you're ready to go.
Just give me one. Okay. Cool. All right. Hi everyone. My name is Camille, and I'm excited. Oh, sorry.
Can you speak a little bit louder?
Sure. Can you hear me now?
Perfect. Thank you.
Okay. You're welcome. All right. So hi everyone, my name is Camille and I'm excited to represent the Smart Mobile Lab team. We have diverse backgrounds and 2 of us have lived and worked in Uganda. Slide. With the COVID-19 crisis happening right now, what's the situation like in East Africa? Well, last week, 12 truck drivers from Kenya were diagnosed with COVID-19 in Uganda, despite the lockdown. It took 72 hours between sample collections and result delivery. Why? Because the only testing center is located 270 kilometers away from the border. As country consider removing the lockdown, can you imagine the number of people that can be contaminated within these 72 hours? We believe that it is possible to improve testing capacity in remote areas, reduce the turnaround time, and strengthen the health system all at once. Slide. At Smart Mobile Lab, we aim to decrease the time delay between sample collections and laboratory testing, increase access to testing, making sure no one is left behind, strengthen the health system laboratory capacity, not only for COVID, but for other diseases as well. How do we do this? Well, let's take a look around. Slide. This is a matatu, a Ugandan matatu, common vehicle that is found everywhere on the continent. It is robust, smaller than a truck, and drives well on difficult terrain. Slide. We want to convert this into a mobile laboratory, capable of bringing the test directly to those living in remote places. It will be designed in a modular way so that governments or private providers can adapt to the national testing guidelines. Let's go back to our Ugandan borders. Slide. Instead of sending the sample all the way to a central site, the mobile lab will be deployed where it is decided by the health authorities. Samples collection and processing will be done on-site by trained staff. While we prefer to adapt to the testing preferences of each government, we could imagine using GenExpert as a solution. Communication results and reporting will be based on the current system in place. This is a flexible way to handle the current crisis. But what happens when we no longer need to test for COVID? Well, that's what the modularity is great about. Slide. As needed, the lab will be transformed into a mobile HIV/TB clinic or support current lab activities. Today, we have a matatu in Uganda. Tomorrow, we could have smart mobile labs all across the continent. The question is, shall we take the ride? Thank you very much for your attention, and I'll be happy to welcome any of your questions.
Thank you. Judges.
Yeah, I have a question.
You can go to the, there is the team if you want in the following slide. If that's yeah.
I have a question about quality control. How do you plan on being able to keep the tests and the matatus clean, as well as ensure that the proper level of testing is happening by these matatu drivers?
So regarding on this content, I'm sure Aaron from our team will be happy to connect and answer that. Otherwise, I'm happy to do so. So if Aaron, you want to say something?
Sure, no problem, Camille. And thank you for your attendance today. And thank you, Rahul, for the question. It's a great question. And basically what we want to do is load the lab with the necessary equipment that's needed to do the sample processing all within the unit. So on our slide, we showed one example implementation where you have a small footprint biosafety cabinet that would allow you to do all the processing of the samples in the lab. And this would employ trained technicians. We could also endeavor to do the training as well. But based on what who we're partnering with, which government, they may also want to send individuals who are already trained in centralized labs on a mobile lab unit out to a remote region. And so it's very flexible. It depends on which situation you want to adapt to. But we'll have highly trained staff with the equipment in place.
I have a quick question if we have time. So in terms of implementation plan, I know that van builds take a bit of time. How can you scale this rapidly enough to make it effective in the near term? Or is that not necessarily your goal?
I think one of the things I believe in is in open science and open source solutions. So I think being like with these resources available in Uganda and knowing the current ecosystem of Africa and like all the current makers, I think like mobilizing a huge community around this could be one of the things we could use to leverage this solution and implement it quite easily and in an efficient manner. We're also considering public-private partnership in order to like just come together and roll out solutions which are efficient and actually addressing a need which is kind of urgent. So
Thank you.
for asking.
Okay, thank you, team.
Thank you very
Smart
much.
Mobile Labs.
Backup slides.
Thank you very much.
All right. Up now is, yep, Camille, if you can just mute yourself. Great. Up now will be A32. Coming up in 5 minutes will be A13, drones for COVID. So if A32 can raise their hand now, so that I can find you.
I'm looking. Who's presenting from team Edward? Is Edward here? Edward or?
Yeah. Hello, can you hear me?
Yes.
Moses, is you? Great.
Yeah.
You can turn off your video
Oh.
just to ensure the sound is better and we can still hear you. Try speaking now.
Yes, you can see me better there.
No,
Can I start?
we don't need to see. I'm actually gonna, yeah, perfect.
Great. Thank you. Moses, are you ready?
Yes, I'm ready.
Great.
All right, go ahead.
Okay, so the major challenges that we as group that do seek to address is the transportation of the patients correction facilities. Can you go to the next slide? That slide, please.
Moses, we're having, I don't know if anyone else, I'm having trouble hearing you. Is there another team member that can help?
My team member is seriously in crisis of the network connection.
Okay, then just go over this slide again because I was not able to hear any of it.
Okay, the second about the problem statements. So majorly we are focusing on the transportation of the samples to the hospital. So based on the infrastructure that is there, how can we make it more better or facilitate that from the remotest site to the testing lab? How can we monitor and ensure that in the shortest time possible that each and every sample is taken and corrected? Then to the extreme sample collection facilities, we can go to the health workers who are commonly available in our areas. Those health workers who are like, we can assume like our chiefs who know the area that they survey how it is. They can use we can give them test kits, like an example, those ones used by ice cream vendors, so that they can go to the home with this mobile app, record each and every the symptoms of a possible person who is affected by this, who has reported cases of, as in, take the samples of that person who has symptoms of COVID, and then by the use of this app, when he submits those symptoms, they are recorded into a central laboratory, central lab. Then that's the samples that he has collected from the patient. Instead of going to the patient to the hospitals, those samples are collected and taken to the nearest collecting center. That collecting center can assemble tests which have been collected and take it to another greater collecting center, whereby these samples now are centralized or collected and stored in one place. So the national laboratories have a simple opportunity to just come and collect those samples at a central place. So the target population which we target is the health workers, who can go to the field, who are in the field, and they have already the smartphone. So the only thing is to add an app on it. This app will ensure transparency that when the health worker has recorded the details of a patient, they are automatically logged into the national database. Now the national database with that data can be able to map as it waits for these samples. How can it divide for the resources they have and the testing capacities? They can divide among themselves, so to ensure that every sample that is collected with the minimum time possible, it can become, we can get the results. So after the results have done that, from the health worker is making the requests, then it goes to the system, then the central laboratories wait for the samples to come and up to the testing center. After the testing center have done the test, it records it takes the request that had been made and fulfill it by recording the requests. So by fulfilling it, that we can send back by an SMS or an email service to the respondent that it came. Also, we can the test tubes that we are using, we can put a serial number. We can be sure from which place where it came from. So the differentiation with other services, with the current system, there are some research I was looking for from India, saying they have done the automation of those lab request forms, but now they have not moved to the extent of using the mobile phones which are readily available to push the healthcare service to the last mile, that a health worker can just walk into your home. When you just call a specific number, it's mapped to that area, and then the nearest health worker comes to you instead of you traveling to the hospital, which you pose a very great list. Then the last slide, the total of her. Oh, sorry. Thank you very much for your time.
Questions, judges?
Any questions, please?
Yes, so I have a question just about the app, development of the app. How do you see this app being developed, and what are the characteristics of the app?
Okay, from the final presentation, which is currently on the screen, on the app that should be the functionality on the user part, or the health worker who is at the final end, should have the whole amount, or the whole details that are recorded here. So the app is just based, you can be an Android phone or a Windows phone, it has this. Then the collecting centers have an app that, this one, it has some master capability of the health worker mobile device. Then the final laboratories will just coordinate their activities of the app. Hope, I'm not sure if I answered you correctly as you required.
Just to clarify, great presentation. Just to clarify that this solution is looking at tracking the samples. Basically, it doesn't consider the collection of the sample, just the process of tracking when it's collected to when it's delivered. Just want to confirm that.
Yes, that's tracking from when it's collected to when the final result is done. So by doing that, we can know.
I'm guessing it has to do with the hours between sample collection and processing. Moses, we've lost you. But thank you, Moses. We're at time. Thank you.
Okay, thank you very much for your time.
Okay. Next team.
Next team is A13, drones for COVID, and coming up will be T-Safe. So if you are drones for COVID, if you guys can be the only ones raising your hands at this moment.
Yes, hello. Good morning, everyone.
Hi, Desire.
Hi. So our team, the name has changed a little bit. It's efficient testing of COVID samples using the drones. So we're a group that thought about how to really use a fast transport of a drone. So can you go to like next slide? Okay. So we wanted to address that because we have seen firsthand that delays in the transport of the samples can really cause some major spread. So Anibe in our team, he has really a medical in the field, and she has experienced firsthand when sometimes the police would have some barriers, and if you were transporting some samples with you, then you wouldn't have been able to go with that in time to be tested. I come from Burkina Faso, and Burkina Faso right now has some major terrorist attacks. So there is no guarantee that if there is a van, a car that is transporting samples will not be attacked on the road. So that is the problem statement that we have. And we want to be able to do a fast transport of that next. So our application is based on these simple components. So there will be a website. That website is for administrators, people who will be receiving requests for sample pickup. There will be a mobile app. The mobile app is for a medical field, a medical doctor, and they can request a sample set to be picked up. So we will have a backend for those website and application, and this is going to be linked to a drone operation platform that already exists and that we have already tried. It's called Flight OS, and that can allow a drone to be to fly from anywhere actually. So it means that the administrator can stay on a website and he can aggregate the request and say that there are like 5 sample sites that are nearby. Let's send a drone, and it will send a request, and the drone will fly from where it was staging to go land, pick up the samples, and come back to a bigger central log. From there, we want this platform to be flexible. So if the drone cannot fly, then you can have a bike or you can have a van. Next slide, please. So the solution is for fast transport. So that's what I explained. Next slide. So that is the application flow. As you can see, it's already existing and we can use it. Next slide. That's an actual drone that we were using to test, and we have made some missions that we can use to test. Next slide, please. That's how the interface for the drone operation works, and we can query that. So what is good is that we can use that. As you can see, we have a diverse team, and we can really implement that because we already have the drone, we have a platform, and we have everything. Next slide. So our team is very diverse. So I work at the National Institute of Standards and Technology at NIST in the US. We have a medical doctor, and we have God's Will, who can do automation and robotics, and we have Shungu, who is doing IoT. And I think that between the 4 of us, we can really make this happen. Thank you.
Questions?
Hi, I love this idea. I think it's very inventive. I wasn't clear on, I understand entirely the drone part in the middle, but I'm not clear about the 2 other ends. In other words, how are the lab tests administered and by whom? And then where do the lab specimens go? Is it to an authorized clinic?
So that's a very good question. So the lab tests are being done in a clinic in a big city, because we are in Africa. That's likely what is going to be, right? So the samples are collected in some locations. It can be a university, a market, and there will be a medical doctor that will have the app that can say that I have collected, let's say 10 samples. And another guy, another market can say, I have like 10 hour samples. And from there, this will be aggregated in our platform, and then someone can decide to send the drone only after that. So there will be some work in doing some routing, doing some efficient testing of that. And also we want to have a fridge to store the samples and also follow the WHO packaging regulations and all. Yeah.
Quick question, if there's still time. So my question is in regards to considering the drone, it's unmanned. The security with regards to a sensitive sample as the COVID collected or sample that has been collected. Your team, have you thought through securing that sample if it's in flight?
Yes, I would like my colleague to answer that. Anibe?
Okay. Hi, everyone. Yes, thanks for that question. The app that will be attached to the drone has an interface that will prompt the end receiver, and as well where it will speak from if there's any temperature regulation. If the temperature has increased, it will tell the central laboratory where the final test will be done that sample should be rejected. So it monitors the temperature as well. So that's I hope that answers your question.
Thank you. I think that's all we have the time for right now.
All right, that's fine.
Thank you.
Great. Up now, we have team 39, T-Safe, and coming up will be 4 Pool Party.
Who's for Team Safe? Looking for a raised hand.
Hi, it's Akshay. Can you guys hear me?
Great. Yeah, we can hear you.
Thank you.
Are you ready?
Yes, I'm ready.
Okay.
Hello, judges, fellow participants, and mentors. This weekend, we tasked our team with a question, why should we care? And create an innovative product keeping ground reality in mind. Next slide, please. Ladies and gentlemen, let's face the reality now. Hospitals in rural areas are not equipped with testing facilities that are required for COVID-19. Simulating pandemic situation, we wanted to implement an idea which is fast, reliable, sustainable, and practical to work with local regulatory bodies. Next slide, please. So here we have a solution that might not be the unique to audience in the room, but what makes us unique is making it work with the community members, hence solidarity and not charity, making good use of resources available and implementing them to the process. We are making use of the community workers. We are opening a helpline number, and we are making use of the local ground people, which is the transportation system available, and using the sample trackers so that we can make sure that the samples are never lost. Next slide, please. Our case study and our market includes Rwanda and Sierra Leone, which is where we were targeting for. And the case study during the case study, we found that there are testing kits that are available in Rwanda in the city, and there are approximately 700 test kits available. And there are hospitals and pharmacies that are available to work with the community health insurance companies. And why we picked up, because during Ebola times, we found that these were the hard-hit areas. And like example, like Mutales accelerated the supply, and they were able to help with the community insurance companies, and they were able to implement it very quickly in those areas. Next slide, please. This is our operating model, and our operating model relies around the community members transporting the samples to the lab facilities. Here we have divided our zones into the honeycomb, where each nurse is going to be provided with a helpline number, or these hospitals will be provided with the helpline numbers, and they are going to text that number, and our helpline center will receive those text numbers. And from there, we will assign the drivers to go to those hospitals and deliver it to the lab facilities. Our drivers will be well equipped, trained, and always made sure that they are safe, and make sure that they are handling the precautions, and they are handling the guidelines as well. once the sample has been dropped, our helpline center is a centralized system which is controlling this whole process and making sure that the messages and the samples are received and deployed properly to the location. And the acknowledgement is also sent back to the hospitals, so that way the whole loop is closed. Next slide, please. These are some of our software designs for the driver apps and from the dashboards, where we found like our drivers will be always be provided with how many samples they have collected, how many are remaining, and how many have been dropped, and what is going to be their next location where they have to pick up the orders. It's not about the internet connectivity. It is also about the helpline. The administrator and the dashboard will be always in touch with them over the phone, so that they can always give them the statuses on where their next location would be. Next slide, please. Financials. We are focused on two fundamentals. Does the solution work per customer basis at any point, and how to grow the solution? With below numbers, our projected growth looks towards the hockey stick growth, where we know that these numbers will grow eventually. We found that approximately initial cost that we would be implementing is going to be approximately $600 per driver per motorbike. And the next cost is going to be the operating cost, which is going to be approximately $10 to $15 a day. This cost is going to be very dependent upon how many samples we receive and how many samples we drop. Next slide, please.
Actually, I'm going to have to ask you to stop.
Okay, sure.
Time for questions from the judges.
Thank you.
Yeah, I'd love to learn more on how this interacts with existing kind of healthcare systems in your target areas.
So we are going to work with local NGOs, and we are going to also work with the hospitals that were, and also work with Mutels, which is the insurance companies locally in the Rwanda. And we are going to contact them and find out the areas that are mostly hit. And we are going to be sending our representatives to work with them to provide, like the administrator will be handling the whole section there, and they will be always in touch. Our ground team will always be there, like Afam and Elizabeth. They are the people who know what the ground reality is, because they are the most talented about those healthcare systems, to work with them daily on how those samples can be better deployed. And we are doing it in a secure group, which is like the boxes will be secured and always be temperature controlled.
Thank you. Maybe we'll go to the next team now.
Great job.
Thank you.
All right, team 4, pool party. Are you ready? We're gonna need to pick it up.
Yes.
Perfect. And then team Alpha, you're on deck.
All right, so my name is Joe Sarhan. I'm a physician scientist in Boston, and we're going to be talking about pool testing to allow for safe reopening of quarantine communities in rural Africa. Next. So African villages have been on quarantine, and they're now going to start opening up. We need more affordable testing to have them open up safely. Next. The solution we're proposing can pretty much overnight reduce the cost of testing by about 30-fold. Next. So typically the way we do testing now is one patient, one test. Next, next, next. We would need 30 samples to 30 test kits to test 30 individuals. Next. So what we're doing now is applying an approach that's pretty widely used in laboratory testing, which is sample pooling. So we can take 30 individual samples, combine them into one group, and just test that one individual group and see whether the result is positive or negative. And the unique application that we have here is that in Africa, there is a low case burden. So if the cases are not very prevalent, then we can rule out a large number of people very quickly using pool testing. Next. We can see that Africa stands out as an area where there are a very low confirmed number of cases. And if that's not the case, we'll find that out using our strategy as well, which would be useful. Next. So we came up with a one-page guide summary for people on the field on how to actually go about doing this testing, how to select the groups. So what we're envisioning is a village with 900 people. We can test all 900 people in 3 groups of 30. And if we go next, we can see that we have
three basic outcomes. If we have more than 2 groups positive, we don't want to reopen that village. And we can go further into sub-testing the individuals within that. With yellow zone, 1 positive group, we need more testing, and green, then that group can interact within itself freely. Next. So we also came up with a 1-page guide on how to physically do the sample pooling and collection. This is based off of published data for COVID testing. Next. So with COVID testing, costs $26.69 in Nigeria for a single test. We can bring that cost down to 89 cents. Next. So we want to work with the World Health Organization to work on outreach, language translation, getting this idea out there for people who can actually implement this on the ground. Next. Next. We are really a diverse group. I'm a resident, soon-to-be resident physician. We have another member who is involved in medicine, 2 engineers, software developers, and someone involved in business management. And I think with all of our diverse backgrounds together, we can really make this work.
Perfect. Judges, for questions?
Is your primary focus rural?
So that's where we were thinking of starting out first, just because there would probably be the lowest number of case burden there. And they're the people who would probably want to interact within each other more so. So clearing up a village to be able to be out of lockdown and interact within that village.
Once you find out that there are a few confirmed cases within a pool, how does that relate to actually treating and finding out the individuals who are infected?
Yes, so that's a really interesting question that has to do with the testing strategy in general. My interest is to just lock down that pool. I don't really care who specifically is positive within that. I just want to lock it down for 15 days. If you have severe symptoms, if you have trouble breathing, you need to get some more help. And if you're a high-risk individual, like if you're older and you're in that group, then we need to be extra careful. But I think we can, the way we're proposing is non-destructive. So we can go back and test individual samples and figure that out, but I think that would be a little bit more challenging to do logistically.
We have time for one more question, actually.
It seems kind of predicated on the people not moving around very much. How would you know when to retest a particular region?
So I think that's, once we would get that off the ground, then we would start thinking about retesting. But to begin with, we just want to get more tests available and do more testing. Because if we wait and the case number starts to grow, then we've already missed the boat, and doing pool testing isn't really going to be applicable anymore. So it's kind of a time sensitive thing.
Great. Thank you.
Okay, great. Thank you. Up next is Team Alpha coming up. A1 Discotheque.
Okay. Who's in Team Alpha? You can read lower hand. Alphonse. Alphonse, can you hear us?
Let me look. We can go to the next one if not and come back. All right. Should we keep going?
Alphonse?
Bonds or Ray?
Okay, Vasundhara or Raymond? Is there anyone else?
All right. Why don't we go to the next one and we can come back? Hold on. Let me jump. All right, Discotheque, are you ready?
Hello.
Hi.
Are you for Discotheque?
Yes.
Perfect. All right.
Great. Thanks for having us.
Sorry, before you begin, Sarah, could you just repeat for the judges the team name, team number for Discotheque?
Yes, it's a good call. Sorry. We are now on A1 Discotheque. Go ahead.
Great. Do-it-yourself community-based diagnostic. Next. An effective way to stop the spread of COVID-19 in Africa is to make a diagnostic available in primary healthcare facilities that are near the communities and also have a minimal laboratory expertise. Nevertheless, current diagnostic infrastructure is not feasible at the PHCs due to 3 primary reasons. First, their diagnostics requires expensive laboratory equipment and resources such as RNA extraction kit that is now low due to the urge. Second, their diagnostic requires high technical expertise. And lastly, time consuming and low in quantity. Next. To resolve these issues, we came up with a do-it-yourself COVID-19 diagnostic protocol that can detect up to 96 samples in less than an hour with a single PCR machine. It requires 4 steps. First is the saliva collection in the PCR tube. Next, we would just have to put it in the PCR machine in a preset thermocycler condition. Then we have to add a 10 microliter RT lamp cocktail with the multi-channel pipettes. And then after the thermocycling, we have to add a cell-free paper disc into the sample that has the sensor, it's a synthetic sensor. And after some time, we can just visualize it without the need of any equipment. And this paper disc sensor can be optimized for other viruses. Next. But what's really innovative about our diagnostic compared to what's available? Well, currently in Africa, there's only 5 tests per 10,000 people. We want to get that up to 1,000. But how would we do that? Well, our innovation comes to the point that it's really cheap, less than $1 per disc. It's fast, it takes only less than an hour. It's cost effective, simple, less training is required. It does not require RNA extraction kit, that is limited. Even here, we had to donate some from our lab. And it's do it yourself. No, it's open source and it's available for everyone, unlike the Abbott diagnostic now. Next. How are we going to overcome this? Well, our synthetic circuit can be further designed and sent for synthesis. I talked to GenScript regarding this. They can definitely do that in a matter of like 2 weeks. And next, you can get community engagement to train them for protocol. We can get public-private partnership, government, public health officials, nonprofit medical groups, and possibly private health sectors. Lastly, we would have to manufacture this somehow. Our way to overcome this is by making a do-it-yourself protocol that we can outsource to Africa itself. Next. I want to thank our team, Adelaide, Susan, Rishruth, David, Balkis. Next. We can further make this to a take-home test COVID diagnostic by fabricating a small microfluidic device that has a possibility, we can just engage some temperature control within the device and have the paper sensor somewhere at the end. It's pretty feasible and it's pretty cheap. This specifically, this was done by View, cost, there's a low cost to these.
Thank you a lot. Questions from judges?
Yeah, I'd love to learn more about what it actually takes to build one of these, as well as how you're going to disseminate the results to different members of the medical community or the patients themselves.
It makes sense. So, so what it takes to make do this is that if you go on the slide number 15, I can better represent that. The paper disc it could be freeze dried many times and is stable in room temperature. So and it's a cell, and making that is really easy as long as we have the synthetic circuit, which is just a plasmid. That should be really easy. Sorry, if you could go further, even further. My apology. Yeah, that's it. And our circuit uses CRISPR system that is easy to multiplex and design. So it's basically like we're left with this easy deployable paper-based disk and some reverse transcription and RNA extraction. We don't need that. We're going to use HUD with temperature change for RNA purification. Reverse transcription is isothermal, no problem. So it's pretty easy. Like I can, if I have all the equipment, I can personally do that in a matter of days.
So what about, have you thought about regulation, getting it through the regulatory authorities in Africa and the timelines for this?
Yes, we actually thought about that. David or Susan can elaborate on that end. Since
all right. So let me answer that question. So we have primary health care at every community in Africa. So what we plan to do, and the primary health care normally reports data via DHIS2. DHIS2 is an open source health management information system. So as the PHC is getting the result from from this innovation, it can be sent via mobile DHIS2 SMS platform. And the local, the national authority will be aware of the result, and they can make necessary arrangements for the evacuation of the positive case.
Great, thank you so much. We'll go to the next team now.
Team 18, team cost. You ready?
No, sorry.
Is that you, Milad?
No, it's not Milad. It's who's presenting from team cost? I think it's Afar.
Vinay, I think it's
Vinay.
See, Vinay. Is it Vinay?
Vinay, we can't hear you right now. No. Maybe try stopping your video and just using the sound. Sometimes that helps with the... Can you try speaking now?
Vinay, can you hear us? Is anyone else from their team able to present? Abhishek?
Sure, I can present.
Before you do that, Sarah, would you just repeat the number of the team for the judges?
Yep, it's team 18, and up next will be A27, Voice of Africa.
Thank you. Okay, and thank you, Abhishek.
Hello all, my name is Abhishek. Our team's name is COST, that stands for COVID Screening, Sampling, and Transportation System. Next. Next. Our challenge is to tackle getting the samples from the periphery to the centralized labs, which are far away. So our problem statement is reaching out to the remote and inaccessible areas, and undue exposure of healthcare while doing so, and conserving the personal protective equipment kits, which is very important. And finally, when you have procured the sample, to get it to the centralized labs, which are far away. Next. So we are hereby proposing an efficient, feasible, one-stop solution called COST, that I said, COVID Screening, Sampling, and Transportation System, which is a rapid, contactless mass screening, sampling, and transportation system comprising of a fleet of 2 vehicles, COST 1 and COST 2, that actually uses the existing healthcare infrastructure with just minor adaptations. Next. So our COST 1 vehicle, you can see it in the video, is
has an infrared thermometer at the front of the vehicle to take the temperature. It also has a mic system, two-way, to screen the individuals with medical history, comorbidities, exposure, and travel, and camera to take the pictures of the identity card and make a database of it for demographics and census purposes. Next, can you play the video, please? This is how temperature will be taken. This is how screening questionnaire will be done, 2 meters apart. And the good part is it's contactless. Can we have next slide, please? So this is cost 2. Once a person screens positive on either on temperature reading or a screening questionnaire, we will ask the person to be quarantined and will inform the cost 2 vehicle, which is again a contactless sample collection facility that has a rear end through which there is a fiberglass. The medical personnel and the patient are separated from each other and there is no contact. We will collect the sample with the hands and the gloves coming out of the vehicle. We'll collect the sample and do the disinfection spray using a cheap 5% hypochlorite. We will also equip the van with the pulse oximeter, stethoscope, and medicine dispensing unit if need be for discretion of the medical personnel. Next slide. Now, finally, when we have procured sample, we will transport it to the central labs using hub and spoke model for optimum utilization of resources which are already existing. For example, the National Laboratory Sample Transport System in Uganda. Next slide. So when we did the cost analysis for these two vehicles, apart from the cost of the vehicle and operation for driver and fuel, just cost of mounting an IR thermometer and mic system and camera, it ended up being about $180, which is a one-time cost, and it can be used in coming months, and daily cost will be less than $1. For cost 2, we have $185, which again will be a very less cost if used per person per day. Next slide. Our cost system is very different. As we said, it allows access to the remote areas, conserve PPEs, avoids exposure to healthcare workers, and efficient use of the transportation network, which is already existing in the Africa. Next slide. Now, this idea is very viable. We have already done the field trial in India, where the ground realities are very similar to Africa. Our per day screening was for 500 persons per day, and it takes less than 1 minute to screen the people. We are in phase for implementing our cost 2 idea in the same town.
Thank you. Time for questions.
Next slide. Yeah, this is our team actually. Next slide.
Okay.
So our team is diverse. Yeah, go ahead. I welcome any questions.
Okay, quick question. Nice present.
I can't hear you. Sorry.
Manuel, we've lost you. You could try typing out your question and send it in the chat. If there's another judge who has a question in the meantime that would like to ask.
Yeah, I have a question. How do you decide where to deploy the different vehicles? And yeah, so what's that process look like?
It's an excellent question, Rahul. Yes, our idea is to first use the existing data in the African government databases and census databases to identify the people in the area who have no access or limited access to healthcare, who are poor and cannot afford the healthcare, and who have elderly population and have higher comorbidities. Identifying those areas and starting and piloting a project from there, and then expanding it to the nationwide is the idea behind it.
And is the idea then that the government pays for the deployment as well as the treatment?
Yes, I think with this low-cost system and efficient system, which is very feasible, I think there will be a collaboration between government, non-government association, and the community leaders within those remote areas, where we'll be using information, education, and communication methods via these vehicles, as well as participation of local healthcare workers.
Can you hear me?
I can hear you.
All right. Just to clarify that this doesn't give into account asymptomatic patients. That's patients who don't come up with symptoms. I see you're screening for temperature, and then if the temperature is high, then you take samples. So it doesn't consider people who might have the virus but are not providing any symptoms yet.
Yes. So when yeah, when we talk about in the screening vehicle, which is cost one vehicle, we have a two-way mic system, which will be implementing a questionnaire. Screening questionnaire consists of symptoms of COVID presentations, medical history, and travel exposure. That's how we'll screen patients.
Great, thank you. We'll go to the next team now.
Thank you.
Great. Next is team 27, Voice of Africa, and coming up in 5 minutes will be team 16, Passport.
Hello. Hello.
Yep, we can hear you.
Okay.
Ready?
Yeah, ready.
Okay.
Hello, everyone. We are team Voice of Africa, and we are presenting an interactive voice recognition system and smart analytics to streamline COVID-19 response. Next. So with the coronavirus making a footfall in Africa, large-scale screening is the single most important task countries are undertaking at present. However, challenges such as logistical constraints in testing large areas, limited healthcare resources, and a stigma around the virus itself are impediment. Additionally, it is advantageous to minimize mobility of citizens and exposure of frontline workers to ensure their safety. Next. So we propose to leverage Africa's high mobile connection penetration to streamline the COVID-19 response, engage multiple stakeholders through a single platform, and use the call data for optimizing resource allocation. Next. One slide, yeah. So in this slide, in part 1, we'll be doing IVRS automated calls to citizens. These are made for random screening to identify hotspots. Citizens will assess themselves for symptoms, travel history, or relevant demographic data like comorbidity or age. If a risk is found, they will be connected to a health professional who will take further action such as asking them to isolate themselves at home and following up with them, shifting them to quarantine, ordering tests for COVID-19, or initiating treatment. Next. Here in part 2, citizens can call on a central helpline number if they think they have coronavirus symptoms or contact history with a patient, and the healthcare professional will take further action. Next. We also propose data-driven prioritization of resource allocation using GIS mapping of resources and the data coming in from the calls. Next. So as of 2019, 75% of the African population has mobile connections. Leveraging this, we plan to make 1 million plus IVRS calls per day for random screening, while conducting 16,000 consultations by healthcare professionals daily. Next. So this method is desirable because of the possibility of early hotspot identification, quick action by healthcare professionals, and data-driven resource allocation. It is also feasible because of its scalability, multilingual messaging through geo-targeting of prevalent regional languages, and no dependency on internet or smartphones. We expect the cost of one call to be around 1 South African rand. Therefore, the total per day cost will be approximately $54,000 for a million calls per day.
Thank you, Prusha. Time for questions.
Yep.
Okay. Judges.
Any questions?
I missed a bit of the beginning. Just to confirm that I think it's over the phone screening.
Yes, that's right. It's an automated phone call which will screen the person via a questionnaire. If the person is found to have relevant symptoms, they can be forwarded to a healthcare professional over the call, and the healthcare professional will take further steps like asking them to home isolate themselves and following up with them every 3 days, or putting them through COVID-19 tests,
or deciding to quarantine them or starting the treatment. And this system can be further implemented with giving access to multiple stakeholders in the system, like the sample collection team, the COVID testing centers, and various authorities, so that they have real-time data on whom to test next, and that can be optimized.
And who would your key partners be on the ground to implement this program?
Well, to begin with, we're thinking of implementing this in densely populated areas as pilot campaigns. However, and the partner in that would be foundations who would be working in densely populated areas in COVID testing. However, eventually we would want to move to large-scale projects with governments, because the real beauty of this thing is to be able to reach out to millions of people through one portal.
Great.
Thank you.
Perfect timing. All right, up next is team A16, and coming up in 5 minutes will be team 24, Covistics. Is 16 ready to go? Passport.
Hi, yeah, I think I raised my hand.
Perfect. Okay, go ahead.
You ready?
Yep, okay. So hello everyone, today I'm going to be the representative for Passport, explaining our design, a model pathogen transport system, and its ability to increase testing capacity. Next slide, please. So creating a specimen transport system respecting timelines, specimen quality, biosafety, and biosecurity standards is a challenge. The current ad hoc system relies on untrained public transport companies and carries the risk of spoilage, accidental release of pathogens, and delays, which compromise specimen quality. We need to figure out how to transport samples without spoiling them and without neglecting safety requirements. Next slide, please. So since this is a public health emergency, there's not necessarily time to reinvent the wheel here. Our idea is to utilize the existing framework for vaccine distribution in the numerous fabrication laboratories in the African region. There already exists up to 90% vaccine coverage in the African region, so we propose to use developed cold chain infrastructure to bring samples back to labs rather than sending vaccines out to the rural healthcare areas. Essentially, we'd like to reverse the cold chain process for vaccines by modifying the same coolers which transport vaccines to transport infectious materials. Next slide, please. In the existing network, which is mainly run by Ministries of Health, vaccine distribution centers use cars and motorbikes to transport vaccines in cold storage boxes to health centers. We propose reversing the direction of this chain to bring samples back from rural healthcare centers in a modified box, which will allow the transport of up to 729 samples at once in a safe and efficient manner, which may be required during an outbreak as we need to test numerous people. Next slide, please. To do this, we need to modify existing cold boxes and vaccine carriers, which you can see on the left of the screen, in order to accommodate the safety standards for sample transport. In our modified design, which you can see on the right, we need to be able to require 3 levels of containment and proper temperature regulation, which we can monitor cheaply in our design in order to ensure the efficacy of the samples. Next slide, please. Our design works with some of the smallest vaccine boxes, so it can be used in a wide range of cold boxes and also regular coolers. The sample is encased in 3 layers. As you can see in the animation, it will be wrapped in an absorbent material before being placed in a plastic baggie and then inserted into its own individual tube slot. And then an individual cap and a group level cap, as shown below, will be in place before the entire design is placed into any carrier that might be able to accommodate cold packs. This can be easily 3D printed, and the design can then be disinfected and reused. Next slide, please. The design is essentially a 3D printed component and a simple temperature sensor, so distribution is relatively simple. Most fab labs will have both PLA in order to print and also simple temperature loggers. We can work with partners at the Ministry of Health to incentivize the vaccine distributors to work in the reverse direction, as well as working with other NGOs on the ground, like Writers for Health, in order to optimize their operations and make transport more safe. Next slide, please. Finally, this is our team. We come from a diverse set of backgrounds and geographic regions, so we are well equipped to bring the solution forward. It is an elegant and simple solution which piggybacks on existing resources and can be used with regular coolers as well as those that are designed already for vaccine transport.
This design is universal, and we believe that it may actually be integral as a component to many of the other solutions that have been presented to you here today. We mainly need the context and logistical support to make this solution a reality, and we sincerely hope you will support us. Thank you, and we'll be happy to take questions now.
Yeah, love the idea. Really like the logo too with the little viruses.
Thank you.
I would want to hear more specifics on just like what cold chains are you looking at right now in terms of vaccine dissemination, like what diseases, what vaccines, as well as what are some of the specifics on like how long can you keep it cold for, what temperature does it need to be at, things like that, as well as costs.
Sure. Kitty, do you want to answer that? You work in vaccine transport and cold chain logistics.
Yeah, sure. So in terms of the vaccine cold chain, we want to take advantage of the existing routine immunization cold chain. So most of the countries in Africa, the vaccine routine immunization are run by Ministry of Health. And so from the kind of like the state level, so the front level, they use bigger cold boxes, and then the further they go along on the cold chain, the boxes become smaller. So for us, we would be using the same mechanism. So for when the health workers go out for their routine immunization, so normally it includes 9 different types of vaccines, so polio, yellow fever, BCG, etc. So by at the same time, when they give out the vaccines, they also take the samples from the villages, from people in the villages. So that's how we are kind of using the existing cold chain system. And you talked about temperature. So for vaccines, WHO recommended all of them to be kept between 2 and 8 degrees. And this is also the same case for the samples for the coronavirus. So between 2 and 8 degrees, and they need to be kept for 2 days. And if so, in our system, we make sure that we have temperature monitoring in each stage, which improves the current vaccine delivery system, because in a lot of remote areas, temperature monitoring is kind of being skipped at the last mile. So we want to improve that and make sure the temperature, excuse me, make sure the temperature is kept from the last end and back to the kind of like the state central testing center. Did I cover all of your questions? Is there anything else?
We don't have time for many more. So thank you so much for the support. We'll go to the next one.
Thank you.
Okay.
Great job. All right. Next up is Team 24 Covistics. And then it doesn't say here, but we'll go back to Team 37 and then we'll do Team 20. There's just some tech issues on my end, so I apologize. But now we'll be Team 24 Covistics.
Hi, everybody. I would be representing Team Covistics.
Great. Thank you.
Next slide. So we represent 6 nationalities and bring diverse experiences from medical research, data science, computer science, user experience, and finance. We have Opiolua, who works actively with the African Center of Excellence for Genomics of Infectious Disease and is involved with active COVID research in Africa. We can also partner with other such facilities. Next slide. The problem we are looking to address is how to effectively bring samples from remote rural areas to central labs, leveraging multimodal transportation. While it may seem that going from point A to point B is simple and seamless, the process in Africa is constantly interrupted by poor infrastructure in underdeveloped areas. Also, specialized training testing can only happen in central authorized labs, which are far away. Next slide. As you can see, Africa is lagging behind in testing per capita, and we believe our solution can help. Next slide. So here you see visually the journey of a sample from a rural community to a central lab. The driver connects with the healthcare worker to collect samples, and then they deliver the package to another meeting point, in this case, the taxi driver, who will then finally take the package to the central lab. There are set up contactless pickup points. So at no point would asymptomatic patients
or there would be any physical touch between two stakeholders. At the central lab, they will pick up new test kits and then return back to the community. Next slide. So become a COVID driver hero. Our phone application will allow persons, whether they have a vehicle or not, to sign up and deliver samples safely. The solution will leverage commonly owned vehicles like bicycles, motorcycles to drive the samples to the central labs. There will also be training given to the COVID driver heroes, and there will be tracking systems for safe last mile delivery, and progressive payments will be made to the COVID drivers at each stage of their shipment. Next slide. Our business model is differentiated by the long-term sustainable adoption even post-COVID, because it connects high coverage, it connects rural communities, it calls for high coverage, and is optimized over the complexity of the system, and is backed by strong technology. We also empower local communities and give them self-reliance. Next slide. We would be recruiting the COVID driver heroes through radio, through social media platforms, and also contacting local taxi worker unions. Next slide. So this is what the app will look like. And as you can see, there is a 3-question simple survey check for COVID drivers while signing up to help us figure out if they have COVID-19 symptoms before actually undertaking the journey. Even at the time of delivery, we will be able to capture feedback on how the delivery. Next slide. We use Grasshopper algorithms to prototype the technology, which will customize the routes according to the mode of transportation. Next slide. All safety standards would be in compliance with UN and the packaging. Thank you. Any questions?
Working with any taxi drivers to see if they're actually willing to transport the material?
So our solution, thank you for that question, would be self-volunteering. We are not forcing a taxi driver to this phone application. If they see this as a viable employment opportunity, a safe opportunity, then they can use their vehicle and sign up for this application.
A quick question. Great presentation, really. Just to think, for those who are in rural environments and may not have access to smartphones, your solution, does it have them in consideration? Given that you have someone who might be, like from the point, the guy who had the bicycle or something, if he doesn't have a smartphone, will they be able to be on your solution if you've considered him? Over.
Yes, there will be phone training and also phone contact support throughout the journey of their shipment. So even if they don't have a phone, they can take help of a local phone, or if they don't have a smartphone, there will also be phone number calling programs. There will also be emergency response, so there would be a helpline number they can call.
Have you thought about security and managing the integrity and quality of what is being transported, so that there is no that it is actual samples being picked up and transported to where they should go?
Yes, I think Opilua on our team can help you with that question.
Okay, so as far as, first of all, security about in regards to the transporters, we'll be providing PPEs both at the sample collection sites and at the testing sites. So they will get PPEs, and also the drivers will be provided with personal PPE equipment, even sanitizers, disinfectants, so that they can end up disinfecting their vehicles and also use the sanitizers if needs to be. And then the samples will be packaged according to WHO guidelines, so helping to avoid issues with spilling of the samples, and proper training to ensure that the drivers know how to are cautious of what to do if spilling occurs, how to take care of such a situation. So we have put all that into consideration.
Okay, thank you. We'll go to the next team. And I think that was Alphonse. Can you hear us?
Yes, I can hear you. Can you hear me?
Yes, we can hear you. Welcome back.
All right. Awesome. Thank you so much.
Sorry, what's the name of your team again? Just to remind me.
37.
37.
I know I need the name.
Okay, it's Tim Alpha.
It's right before discotheque.
Okay, hold on. I'm sorry, guys.
I think it's actually further down.
Thanks.
I was looking.
This is another team.
There we go. Thank you. Ready?
All right, so just a few tests. Can you hear me?
Yes.
And sorry, just before you begin, Team 20, you will be up next. I'll just have to stop sharing and pull it up separately.
Okay, so I'm gonna start now then. All right, so our team focused a lot on developing a kit that will enable us to detect COVID-19 in patient within hours. Next slide, please. So as you all know, COVID-19 is an important disease, actually global pandemic, and affects every continent. And the reason why it's so important is because we don't have any vaccine at the moment or any proven cure that works, scientifically proven. Next slide, please. And in Africa, luckily, we are not that affected compared to other continents because eventually we are able to adopt swift lockdowns. But the problem with this lockdown is that the continent cannot sustain a lockdown in longer periods than other continents due to economic reasons. So we need to find a way to be able to detect this virus in time so that we could control the spread. Next slide, please. So at the moment, methods are based on PCR and antibody detection, which are actually, they are accurate, but the only problem with these is that it can take days from the sample collection until the result delivery. And most of the kits that are needed for this also need to be imported. Some country need to import various of this kit as well. It's not everyone that can afford it. Sorry. Next slide, please. So our solution is just is very simple. So with this idea, we were able to determine that it would take about 2 hours from sample collection. So the first step eventually is going to be the sample collection. So we have to collect the sputum or we use the swabs to collect the virus, the cell sample. And then we have to lyse everything, so to break open all the cells so that the genetic material can be released. Next slide, please. And as we know, so coronaviruses are close with RNA virus, so we will need to convert the RNA into cDNA using the reverse transcription. Next slide. Yes, next slide, please. So this whole process is just based on detecting fluorescence using molecular beacon that are going to hybridize a virus-specific target on the RNA sequence, and all that can be amplified. Yes, it can be amplified. And when the attachment of the molecular beacon happens on the target DNA, it's going to release a dye that can be observed using fluorescence method. Fluorescence observation, sorry. Next slide, please. And the reason why this can be significant is because the entire process can be within 2 hours, and also that eliminates the amount of time you have to wait between sample collection and delivery of the result. Several samples can be tested at once, and we make a rough approximation for all the reagents needed for this. So it's going to need around $300 to make 50 reactions.
Great, thank you. Questions?
All right. Any question?
Yeah, can you talk about some of how the equipment needed to do some of the more technical and scientific aspects of the testing, like the fluorescent lights and all of that, how that will be kind of procured and distributed along this, along these chains?
Okay, so some country are actually able to synthesize these molecular probes here in Africa. So I do not know much about the price. I think Vasundra, one of my members, actually made the approximation for this, but the total added up to 300 reagents. So in that $300 for the reagent, we're eventually going to need all the reagent that we need to make the reverse transcription reaction. So we're also going to need the equipment for the plates, which are relatively cheap because they can be made out of a cheaper material. And so mostly it's reagent, but why we chose this method is because we wanted to eliminate the transfer of samples from, for example, where they collected to a medical facility where they can be tested. So with a simple, I forgot how to call it, but with a simple kit, let me just put it that way. So we'll be able to, to mix everything within one tube and perform the reaction. So eventually we're gonna need an incubator, so which is also gonna need to be included for it to be able to make the reaction. But that's just the basis of what we're trying to do. But we still need to optimize this method at some point, yeah.
Thank you. I'm glad you could make it.
Okay, thank you.
Great.
Thank you.
I'm just going to pause my share for 1 minute and pull up the other presentation. But it will be team 20. So please prepare. Just give me 1 second.
And I believe this is the last team, right?
That's correct.
That's great. We're running a little bit over, but this is the last team, so maybe just 10 minutes over. Judges, if you can stick with us and everybody else.
It'll be a manual. If he's there. I believe this. Oops, this is the wrong one.
Who's speaking on behalf of team 20? Is it Afam?
Okay. It might be a manual.
Okay.
All right. Can you guys see my slides again? All right.
We can see your slides, yeah. I don't see you speaking on behalf of team 20. Oh, Emmanuel? Emmanuel?
Hello?
Hi.
Other one. No,
Sorry, Emmanuel, the participant, not the judge.
Okay.
Oh.
In the mothers. Okay. So what the?
Oh, is it Arshia?
Who's speaking on behalf of team 20? Please raise your hand or write in the chat. Okay. Oh, is it none of these? Is it Arisha? Hi.
There's a couple people waiting to be let in, Elizabeth and Camille. Is there any chance it's them?
No, but I'll let them.
Arisha, is that you?
No, I'm not presenting. I've presented on behalf of COVID-19.
That's what I thought.
Okay. I'm gonna pause my share for 1 second.
Okay. You guys, for a presentation that's being held over 3 continents, we're doing for four continents. We've not had as many technical glitches as I was expecting.
That's right.
Wow, it's possible. This is possible. This is what I have learned.
I agree with you.
All right, it looks like the team is maybe Emmanuel Donzo, Nathan Uchtman, Rashi, Vinay, or Vivek.
Rashi.
Any of you guys here?
I'm wondering if they're just
not in the waiting room anymore. Oh, Emmanuel messaged me. Sorry, guys. Thank you for your patience.
Oh man, the anticipation on how waste management is tied here it's really rising.
Part of me is wondering if he's like on a different Zoom right now.
I'm wondering the same.
In a different track.
I'm wondering.
That's why I paused the share.
Yeah, I actually have a feeling that they might be in a different track and they have submitted. This is probably why they did not submit this through the form. Sent them an email. We might be done, you guys. Anyone else want to say anything else? Because I think then this is it. I want to thank you all for all of your really hard work over this weekend. You guys have been rock stars, working across all of these different continents, across a crazy schedule that we've all been through. Thank you so much to the judges for spending their weekend with us, acting as mentors and judges through the weekend. And then Sarah, thank you so much for running this incredible show. I would have done it.
Yeah, sorry, just for everyone's clarification, they were on a different track. So sorry about the confusion. Apparently they started on A but moved to I. Thank you guys so much for everything. Judges, I'll ask you guys to stay on. But if everyone else can leave the meeting, and the results, the Zoom link for the results will be shared on the overall announcements.
Yeah, 3 p.m. See you guys there. Judges.
Great job. It was great to work with everyone. Amazing work.
Thank you.
Seriously, amazing work in 48 hours. It was super impressive.
Wow, that's true.